So we are honored to have today with us with none other than Professor Michael Bookman. So Professor Bookman is currently the Director of Gynecological and Oncology Therapeutics, Kaiser Permanente, Northern California, San Francisco, and International Relations, Executive Board, GCIG. He graduated from the Massachusetts Institute of Technology and Harvard Medical School by residency training at Beth Israel Hospital in Boston. In 1988, after completing a senior staff fellowship within the medicine branch of the National Cancer Institute, he joined the Department of Medical Oncology at Fox Chase Cancer Center in Philadelphia, where he remained for 21 years, most recently as Vice President of Ambulatory Care and Clinical Research. In September 2009, Dr. Bookman joined the UA Cancer Center in Tucson as a Professor of Medicine and Chief of Division of Hematology Oncology in the UA Department of Medicine. In October 2014, he left those positions to join US Oncology Research as a Director for Gynecological Oncology Research and became a staff physician with Arizona Oncology in Tucson to pursue private practice in gynecological oncology. For more than 20 years, he has worked closely with the Gynecological Oncology Group to support clinical research for women with gynecological cancer and mentorship for junior investigators. His role have included Chair of Developmental Therapeutics Committee and the Committee of Information Technology. He has served as the Chair of Ovarian Committee since August 2010, including its transition to NRG Oncology as part of the NCI National Clinical Trials Network. In addition, he served as a PI for an international collaborative phase 3 trial for women with advanced ovarian cancer, which enrolled over 4,000 patients to evaluate new chemotherapy treatment combinations. I would request Professor Bookman to please come on the stage.
Well, thank you very much for the opportunity to speak with you tonight and for the nice introduction. So I want to go back about 30 years. And when I first learned about clinical trials when I was a fellow at the National Cancer Institute, I also learned a little bit about gynecologic surgery. I learned how to do laparoscopies because the medical oncology fellows actually did staging surgery for the ovarian cancer patients and lymphoma patients. But I don't think you would want me doing surgery today. My focus is more on translational research. And I've watched with some concern how it's become very difficult to design and execute a good clinical trial today compared to what it was like 30 years ago. It's incredibly expensive, time-consuming, complex, requires all kinds of laboratory support, very rigorously audited and controlled and regulated. And part of that is because clinical trials have not had as much support from foundations and governments and other agencies. Most of the support has come from the pharmaceutical industry. And so the main goal of many of the trials that we run today is not necessarily advancing science or answering important questions. It's how to get drugs approved so they can be marketed. And I'm not passing judgment on that. I'm just giving you some observations on how things have changed over the last 30 years. So it is hard right now to even bring young people into the clinical research universe because the opportunities that I might have had to design concepts, submit it, have it reviewed, get funded, and run trials, many of those opportunities don't exist right now for many of the younger investigators who would like to do clinical research. So we do work hard within our groups to try to mentor and support young investigators, both through societies around the world, such as Society of Gynecologic Oncology in the United States, International Gynecologic Cancer Society, IGCS, and we also work mentoring through GCIG, not including individual investigators, but also individual countries. And it's been my pleasure to really work with my colleagues here in India over the last 15 years to try to understand how this world is different than my world, but how we do share common goals and common direction and try to accomplish things. And I've learned an incredible amount from the various meetings I've participated in over the last 15 years or so. And it's allowed me to take ideas back to my country. You know, for example, not all clinical trials should cost $40 million and require 2,000 patients over 10 years. You know, there are what we call pragmatic studies that could be designed to answer important questions that are not going to be supported by the pharmaceutical industry ever. And in many cases, those studies would not be supported by governments or national cancer institutes or other organizations as well because of the limited funding that's available and their focus on different questions. So the partnership here to help grow the research collaborative effort in this country does many different things. It supports the physicians and young investigators here. It supports your patients with cancer, develops new drugs, but it also supports the rest of the world, because you can do things here that I cannot do in the United States. And I think that that's an important lesson for me to learn. So I really do appreciate that. Now, what I'd like to do tonight, in honor of Dr. Oza's efforts and my own, provide a bit of a lecture on the current status of molecular diagnostics to help guide future collaborations as clinical research moves forward. I'm not going to speak in detail on all the slides I have, but I will leave the slides for those of you that want to review them in more detail. So I have more slides than I will spend time talking. Otherwise, you will be late for your dinner. So I will try to be somewhat efficient with that. So first, cervical cancer. A very important issue around the world, especially in India, and changes taking place and how that's being addressed. And we all know that that's triggered by chronic infection with HPV and how that occurs, and it gets integrated and over a period of time becomes cancer. And it's quite impressive that it can take over 15 or 20 years from the initial infection until an invasive cancer evolves, and that there are many opportunities to intervene during that period of time with vaccination, with screening, and so forth. And so this is a critical part of the biology of this disease, and it affects how we treat it and how we understand it. So the vaccine, we know it prevents infection, but it doesn't really impact chronic infections, pre-invasive disease, or invasive cancer. That it's important to immunize everyone, not just women, because we want to reduce overall transmission in everybody. There are also non-cervical cancers that, of course, are HPV related. And we're now seeing, as the vaccines and screening become more effective in certain areas of the world, the emergence of more HPV negative cervical cancers and our increased recognition of these cancers, particularly the gastric type adenocarcinoma. And we'll come back to that in a bit. So, you know, and then something that's kind of interesting is just how countries like India have taken the lead on using vaccines more efficiently, with instead of giving 3 injections, maybe 2 or maybe even 1. And this is it's hard for me to give this talk without thinking about what we've been through over the last 3 years with COVID and vaccinations. And I certainly congratulate the pharmaceutical industry on finding a vaccine that only lasts for 6 months and has to be repeated endlessly in order to maintain immunity. I think that was a very ingenious strategy. So I'm hoping we can learn from that experience as well. So in this setting, how do we take care of our patients with cervical cancer? Well, there are a number of prognostic factors listed here. I won't go through those. But first thing we need to do is really stage and understand the extent of disease, decide if they can have more limited interventions, including fertility-sparing surgeries. And in the absence of being able to do that, radiation with or without concurrent chemotherapy for more advanced disease, then do they need to have additional chemotherapy afterwards or brachytherapy? And what about recurrence or patients who present with more advanced disease initially? The role of chemotherapy, the role of anti-angiogenic agents, and the role of immunotherapy. So this paradigm has changed a lot over the last 15 years. Now, this trial through GOG 240 established the role of bevacizumab in combination with chemotherapy. And there was a platinum-based regimen and a non-platinum regimen, and they seemed to be equivalent. So the data were combined for those two arms, and the end result was to look at the advantage that occurred with the addition of bevacizumab. And what's striking is that in contrast to ovarian cancer studies with bevacizumab, which have not consistently shown any impact on overall survival, this one and only study in advanced cervical cancer showed a very clear impact on overall survival. And this is in a disease where VEGF is not as aggressively overproduced as in ovarian cancer. So it's funny that a drug that targets VEGF in a disease where VEGF is not as prominent an active part of the disease process, nonetheless had a striking impact on progression-free and overall survival. The reason for that, we think, is because cervical cancer is difficult to treat after the first-line treatment. And so what you do during that first-line treatment impacts not just the response rate and progression-free survival, but often impacts overall survival because it's hard to have second or third line treatments in women with advanced cervical cancer compared to ovarian cancer, where women may receive 5, 6, 7, or even more different lines of therapy and with efficacy. So again, understanding the underlying biology of these diseases is important. Now, the next thing that happened was immunotherapy. And as you know, pembrolizumab as a single agent demonstrated about a 12% response rate in tumors that had at least 1% expression of PD-L1, 12%. And it had a progression-free survival of about 2 months, but and a duration of response that was interesting. So when we looked at historical data from GOG phase 2 trials, you can see that in advanced cervical cancer, the median progression-free survival is about 2.5 months on these trials, with the only exception being the yellow line toward the right, which is bevacizumab, which actually seemed to have a little more benefit than chemotherapy for these patients, and that led to the randomized trial. This is the data with pembrolizumab. It looks every bit as bad as the data with chemotherapy. So in fact, this is the overall response, the overall survival data. If we just had the response rate of 12% and the progression-free survival of 2.1 months median with pembrolizumab, it would never have been studied any further. We have said this drug is inactive in cervical cancer. But yet now it's one of the most important things that we're working with to try to help our patients. So it's understanding the biology and knowing what variables, what laboratory endpoints, what translational endpoints are important. So then pembrolizumab was combined with chemotherapy in this trial and others. This is just one example, the Keynote 826. And most of the patients with squamous cell, as you might expect. Many of them have had prior chemoradiation, and some had bevacizumab and some did not. And you see here that looking at the response rates and also the duration of response, that it was active regardless of whether you looked at the entire intent to treat population, as shown in the middle, or the populations with high or low expression of PD-L1. And so this was very different than the results that were seen when pembrolizumab was used as a single agent. You would not expect a drug that had a 12% response rate to give you these data. So something happened in this disease when the chemotherapy and immunotherapy were combined with or without bevacizumab that changed the nature of treatment and changed the success. So these are the overall survival data. Again, you see that it was an advantage also in the intent to treat as well as the different populations with PD-L1 expression. So what are we learning from this? Well, you know, in my lifetime as an investigator, therapy in cervix cancer has moved from single agent platinum to combination with Taxol or paclitaxel, combinations with paclitaxel, platinum, and bevacizumab, and now a 4-drug combination with platinum, paclitaxel, bevacizumab, and pembrolizumab, and other checkpoint inhibitors. How can we do that? This is incredibly expensive, complex, many side effects to manage and be concerned about. and has to be given for 2 years based on current clinical experience with checkpoint inhibitors. This totally changes the way we take care of patients with advanced disease, and it's a big commitment for everyone involved, including the labs doing the correlative studies. So we've made advances, things have improved, but there are a lot of questions. I mean, cervical cancers have low tumor mutation burden, they're proficient in mismatch repair, they're microsatellite stable. They shouldn't respond that well to checkpoint inhibitors. They don't have any of the normal criteria that would generate a good response. PD-L1 status has not been a great predictor of response either in this population. So what are we left with? We're left with maybe the role of HPV viral antigens as being triggers for immune response. And that's an obvious question that we've had now for many years. It's not been answered. It's, again, why do we need to answer it if it's not going to help get a drug approved? And that's the sad state of clinical research in some ways today. So no one's actually taken any of the data from the studies that have been done and helped us understand what the role of HPV is. And we have no data on HPV negative cervical cancer, which, as I mentioned, is becoming more of an issue around the world. So, and molecular markers to help predict response are missing. So here are great opportunities for studies that can be done right here in this country with the resources that you have today to help us understand how to better manage this disease around the world and do it right. So I think that this is a great opportunity for you here. So to conclude the cervical cancer, obviously, I need to say prevention through vaccination and screening is still the most important strategy that we should be thinking about, and I'm pleased to hear the progress that's hopefully going to be made there. But the cervical cancer is unique because it's so dependent on this very structured, choreographed process of HPV integration, which results in inhibition of tumor suppressor genes in a very predictable manner and produces a tumor that doesn't have a lot of other mutations. It doesn't need to have a lot of other mutations because the virus has done the work to set up the cancer development. And so, and then of course these non-HPV tumors are important. We need to understand how to stratify patients with early stage disease. And this is an area where something like circulating tumor DNA could really play a role, because that normalizes very quickly after surgery. And if it doesn't normalize, perhaps that's a population where you really need to give adjuvant therapy, when other people you might not need to do that. But this, again, is something that needs to be prospectively studied. Some of our assumptions about how circulating tumor DNA might work could be entirely wrong, and we do need good prospective trials to address that. But I think that, again, is something that certainly could be done here. So in advanced disease, I already mentioned the things that we need there, and now we're going through a new evolution with antibody drug conjugates. So now we have to not only screen these tumors and treat them with chemotherapy and immunotherapy, but we have to see what antigens they express on the cell surface that might react with these antibody drug conjugates, which seem to be a very potent way to treat some cancers. So a lot of laboratory correlates here for sure in the setting of cervical cancer. Endometrial cancer. This is what's gone on with the American population shifting from blue to red over the last 30 years or so. And I don't mean by blue and red, Democrat and Republican, I mean people dealing with obesity. And we know that that's a risk factor for a variety of cancers, but the endogenous estrogen production, insulin-like growth factors, and other things are very important to the development of endometrial cancer. But that's not the whole story, and it doesn't clearly explain the increasing incidence that we are seeing of high-grade, hormone-independent endometrial cancer, and in particular in the African American or black population in the United States, raising a lot of questions about environmental exposures, socioeconomic status, and other factors to contribute to these diseases, including access to care. So we used to just think of endometrial cancers as type 1 and type 2. Type 1 being well-differentiated, low-grade, hormonally responsive, related to hyperplasia. Type 2 being the more high-grade cancers that occurred in older women not hormonally dependent, etc. And we know about the molecular alterations that make these two very distinct groups of tumors. And this is what we would teach our fellows in training. And this has been followed up by more detailed genomic analysis highlighting genes such as KRAS, which are mutated more in the type 1s, and TP53 or P53, which is aberrant more in type 2, HER2, which is seen more in type 2, and etc. So here's a case to think about here. 56-year-old woman with postmenopausal bleeding, couldn't have an office biopsy because of cervical stenosis, underwent hysteroscopy and found to have an endometrioid cancer, grade 2. And then underwent full surgery, which was found to have a grade 2, 3.2 centimeter lesion with less than 10% myometrial invasion. Did not have lymphovascular invasion. I'm sorry, Dr. Narayan, we'll come back to that point though. No cervical involvement, and lymph nodes were negative. So this is the primary tumor. This is a lymphocytic infiltrate that was seen around the tumor. And this is an isolated paraortic lymph node that was positive, a so-called skip node, because none of the pelvic nodes or other nodes were positive. So how did the tumor get to that paraortic node, and why is it just there and nowhere else? There are pathways of lymphatics that can do that. But this is actually a characteristic of tumors that are mismatch repair deficient. The autoimmune lymphocytic response generated by all these mutations and neoantigens, and so the ability to skip around a little more to different lymph nodes. So the tumor was positive for estrogen and progesterone receptor. It was negative for P53, and I mean it was wild type P53. And here's the screening for MMR proficiency. You can see the good expression of PMS2, but the loss of MSH2 and MSH6. And we know now that this is part of a family of genes that is responsible for DNA mismatch repair, and that one can get to a state of mismatch repair in different ways, with mutations in genes, with inherited Lynch syndrome genes, and also with methylation of the promoter for MLH1, and there are other mechanisms as well. And some are more impactful than others in terms of cancer development. So, but this was clearly a case of loss of a gene, and then what's happened is that with TCGA, we now come to break down endometrial cancers into more different types, and particular 4 types that are familiar to everyone here that we did talk about today. But of course, the ones that get our immediate attention are the P53 aberrant copy number high, and the poly ultramutated, which have a very good prognosis due to the high tumor mutation burden, and then microsatellite instability in the middle, and then copy number low being everything else. And then that's been correlated with progression-free survival and with overall survival. And that data has been recapitulated in a number of other studies, and most recently in the PORTEC-3 trial, which involved adjuvant radiation and chemotherapy in high-risk endometrial cancer. And you can see the extraordinary survival of the poly with the blue line at the top, and the worse outcomes of the patients who had the serous-type carcinomas with aberrant P53. So here's another case, 42-year-old with abnormal bleeding, and then biopsy showed complex hyperplasia in atypia. She had therapy with hormones for a little while with some improvement. Eventually, CT scan and a couple of years later showed a 12-centimeter left adnexal mass and changes within the endometrium, as well as an elevated CA125. And so she underwent hysteroscopy with biopsies, an endometrioid adenocarcinoma with secretory mucinous and squamous metaplasia, so a very diverse looking tumor, and variable grade between 1 and 2, and this tumor had lymphovascular space invasion. It was hormone receptor positive, it was wild type P53, and was proficient with mismatch repair. And these are the CT scans. You can see the large adnexal mass pushing the uterus out of the way, and so the bulk of the disease being extrauterine. And in fact, at surgery, there was a 5-centimeter uterine mass, which was the endometrioid adenocarcinoma, as said. 70% invasion with LVSI, and then the ovary had the 12 centimeter mass with adenocarcinoma as well. Everything else was entirely negative. There was an area of endometriosis and a sigmoid nodule. So this was staged as a PT3A or FIGO 3A. And so what would you do for treatment in this case? Is this ovarian cancer? Is this endometrial cancer? Is this synchronous primaries? How are you going to manage this patient? And so the next step was to look more closely at the pathology. Here's the endometrium, and there's the left ovary, both high and lower power. And you can see that it's the same. And we now know through very elegant studies put together by several groups, including the British Columbia pathologists, that these are clonally identical. So we might think of this as synchronous primaries, but it's one cancer that's growing in two locations. And how it got there, we could talk about later. But it is one cancer involving two different sites. So what would we do for treatment? So this, I gave you the history before. What was interesting is that tumor molecular profile for this patient showed poly ultramutation with a high TMB score and microsatellite stable, which is characteristic of poly mutations. So that was probably why there was such heterogeneity of the tumor. And it also then now again raises questions about management due to the excellent prognosis that women have with poly tumors. But this is stage 3 disease that's now been resected. So what do we do in terms of postoperative radiation or chemotherapy in a situation like that? And I'm just posing the question to think about because we don't today know the right answer. In this case, we ended up that she was recommended to receive vaginal brachytherapy and surveillance and has done well without recurrence of disease. Now, I suspect most of you would want to have given her chemotherapy. Maybe I'm wrong. Maybe not you. Stage 3. But yeah, very interesting case. So 12 centimeter ovarian mass. And then, of course, we can consider immunotherapy in the event of recurrence. So now, switching to immunotherapy, the big thing that's changed in the last few years has been the development of this combination of lenvatinib and pembrolizumab. And this is very exciting data because a 40% response rate, long-term disease control, and improved overall survival, et cetera, approval for treatment of recurrent endometrial cancer. And it works equally well whether there's proficient MMR or deficient MMR, microsatellite stable, microsatellite not unstable. And that does raise some questions. So what's the role of lenvatinib? What's the role of pembrolizumab? And how do we know? Well, lenvatinib is a very interesting drug. I mean, it's a multi-targeted tyrosine kinase inhibitor with an anti-angiogenic focus. It hits VEGF receptors, FGF receptor, PGFR, KIT, and RET. And by itself, it has a response rate of close to 15% in endometrial cancer. I suspect it might actually be higher. And it was hypothesized that it would make tumors more responsive to immunotherapy. But what's interesting is that this entire regimen was studied and approved without single-agent comparative data. So the randomized trials compared the combination to chemotherapy. It did not compare the combination to the individual single agents. And that's unusual because in the United States, FDA usually requires that the role of each agent in a combination be rigorously established to make sure that you need the combination and it's not just individual agents. So this was a case where they made an exception and approved it differently. And this is the randomized phase 3 trial that actually, as I mentioned, compared the combination of lenvatinib pembrolizumab to chemotherapy, physician choice, and showed an improvement in overall survival as well as progression-free survival and response rates. So very impressive. And it received full FDA approval and it's widely in use today. And this is not an easy regimen to use. The lenvatinib can have very diverse toxicities that interact with the toxicities of immunotherapy and very challenging to manage patients on this regimen. Now, we don't know the right dose, the right schedule. There's so many questions that we have about this. We're handed this finished product that's completely unfinished. And in many cases, in fact, it may be just the lenvatinib that's responsible for many of the responses that we're observing, and not the combination or not the immunotherapy. But we don't have a good way of knowing that for many of our patients. So this shows you as well that it worked across a variety of histologies, including serous tumors and clear cell, which are generally very similar to serous and clear cell ovarian tumors. And so that's now raised question of how well we could use this regimen in managing recurrent ovarian cancer. And there's limited data from the LEAP-005 trial to document that it does work, and I've used it in some patients, and it's been quite impressive, particularly in clear cell disease. So I think that we're now seeing a blurring of the lines. What's ovarian? What's endometrial? How do we know? And what do we do? Do we treat ovarian cancer as endometrial cancer, or do we treat ovarian cancer as a completely separate entity? And we'll get into that in a second. So the impact of molecular diagnostics in endometrial cancer, you know, we've really evolved from the type 1, type 2 to really look now at the different subsets from TCGA and others, from PORTEC3 and other studies. But the NSMPs, which are the non-specific mutation profiles, they're still a high proportion of the cases that we have. And now they're being further subdivided into more low-grade classical endometrioid tumors with hormone expression, and then more varied tumors that are still part of the NSMP grouping. And that's clearly going to be broken down further as time goes on and more studies are done. I think that to me, the most challenging thing is that we don't really understand how to use hormonal therapy very well in these tumors, even though it definitely works. It's an understudied area. Again, it's a perfectly good question, an important question that could be addressed here and treating patients with hormonal therapy and answer that for the rest of the world. We also we can't always translate directly from deficient MMR screening, which is immunohistochemistry based, to microsatellite instability, which is based on next generation sequencing. We've had a number of patients who have been deficient for MMR, but then when their tumors were tested, were not MSI. And so MMR does not always equal MSI, but that's not what we're currently told. We're told that they're roughly equivalent. Well, roughly equivalent could be 80% of the time. Even have a patient with Lynch syndrome clearly has dMMR, but the tumor was not MSI and had a P53 mutation and was basically behaving as a serous cancer that occurred in a patient with Lynch syndrome, but it was not dependent on Lynch syndrome for development of the cancer. So those double classifiers are raising a lot of questions, you know, because you get bystander mutations and things like that. So again, here's another opportunity where circulating tumor DNA may assist with deciding who should receive adjuvant treatment and what kind of adjuvant treatment. So finally, turning to the ovary, one of my favorite topics. Amit's probably seen this slide many times over the last 20 years, right? So we used to tell people that ovarian cancer developed from this thin layer of cuboidal surface epithelium that got caught in these ovulatory cycles and got developed into a cyst, and then that would develop into cancer. And it's true, the ovarian surface epithelium is very interesting. I mean, it's tumors frequently involve it, and it's but the ovary is a great place for tumors to take up residence. It's the Airbnb of tumors. You know, I mean, it's there's ovulation, which causes cyst formation, angiogenesis, cytokines, wound healing, all the things that a tumor would like to have. Plus, it's right out there in the peritoneal cavity. A cell does not even have to cross the basement membrane to attach to the surface of the ovary and grow into a tumor. It almost doesn't even have to be invasive. So that's one reason that ovarian cancer is widespread in the peritoneal cavity at diagnosis, because of the favorable circumstances like this that don't require deep invasion. We also used to be taught that the reason we got serous tumors, which look like fallopian tubes, is through a process of metaplasia. And you can see metaplasia is repeated down the entire right side of the screen. So in other words, somehow by magic, these ovarian cancer cuboidal cells turned into all these other different types of cancers. Nowadays, we have kind of a different view. I mean, it is true that these are germinal cells, they retain mutations, and you can construct a very elaborate and interesting theory about how these cancers develop. But I don't think it's true that they magically turn into all these different cancer types through metaplasia. And that's now become a more accepted view. So if we look at where ovarian cancers come from, here's an example where you see a normal fallopian tube with ciliated and secretory cells. Here's a cyst in the ovary surrounded by stroma, lined by cells that look just like the fallopian tube. So did those cells get there by implantation, or did they get there by transformation? And the current theory is, and I think it's probably true, that it's implantation. Cells float off the fimbria of the tubes, they attach to the surface of the ovary, they get caught in a cyst, sometimes they develop into cancer. And that makes a lot of sense, and that's probably what happens with endometriosis and clear cell tumors, and even with some mucinous tumors. So the real question is, are we taking care of women with ovarian cancer, or are we taking care of women who have tumors that involve the ovary but don't have ovarian cancer? And most of the time, that's probably the case. So that's a bit of a transformative way of thinking about things. So, but the ovary is a nice home for tumors to grow. So we now recognize all these different subtypes of ovarian cancers, or tumors that involve the ovary. And they're very diverse in terms of their clinical behavior, their propensity to spread, molecular alterations, etc. And the way we treat them is different as well. And there's more. I mean, this is just a limited list of the common ones that we see. How many of these are truly ovarian cancers? I don't know. I don't know if any of them are truly ovarian cancers, to be honest. I mean, a true ovarian cancer would be a germ cell tumor or a stromal tumor, but not necessarily an epithelial tumor. So the other thing that helps to put this in perspective is remembering how different early stage ovarian cancer is from advanced stage ovarian cancer. In early stage ovarian cancer, only 25% of those tumors are high-grade serous. Most of them are other types that don't spread as much as the serous tumors, and it would be wild type P53, non-aberrant, etc. In advanced stage disease, we know over 80% of the tumors are high-grade serous and prone to spread, and that the tumors that are not prone to spread represent a minority. So that's telling us that also the biology is really important in understanding treatment and how you would take care of the patient and what the risks are for the individual patient based on their histology. So here's an interesting case. This woman came to see me after not being happy with her current oncology care. I get a lot of second opinions. 75-year-old who had a new onset of atrial fibrillation, went to the emergency room. She actually is a retired emergency room physician. At the time of being evaluated for atrial fibrillation, she was found to have complex bilateral adnexal tumors, tumors around her liver, a splenic lesion, pleural effusion, axillary lymph nodes, and a breast mass, and an elevated CA125. And biopsies showed that this was ovarian cancer. And it was called high-grade serous cancer with aberrant P53, and then other markers as noted, stage 4B, and no germline mutations were seen in her routine genetic panel. So she was treated with neoadjuvant chemotherapy with carboplatin and paclitaxel for 3 cycles, and nothing happened. The CA125 was the same. The CT scans were the same. No change. So what's her diagnosis? Low-grade serous cancer. There was a mistake. So her tumor had a mutation in KRAS, which you don't find in high-grade serous cancer. That's common in low-grade serous cancers. There was no mutation in TP53. What happened was the slides were overstained for P53 and they were misinterpreted. So it was called P53 aberrant. It was really P53 wild type. So this is a lesson for diagnostic pathology right here and for our interpretation. None of these tests are 100% accurate. They all have false positives, false negatives. You need to be aware of that. So her diagnosis was changed. We put her on letrozole, and she's been stable for 2 years, has been traveling the world and enjoying her retirement, still has disease, but asymptomatic and not having to have chemotherapy, and very grateful for what she's had so far. So that's an interesting story. I was going to touch a little bit on the early stage data just to sort of remind folks that we don't really know what the role of chemotherapy is in early stage disease. These are trials that showed no benefit from 3 versus 6 cycles, for example, or from adding maintenance with weekly Taxol. But when the data for the 3 versus 6 was broken down by histology, you see here in the yellow that for serous tumors there was a big difference between 3 and 6 cycles. For the non-serous tumors like endometrioid, it didn't matter. So people have interpreted that different ways. And I would interpret it that we probably should treat high-grade serous cancer the same, whether it's stage 1A, 1B, 1C, 2, 3, or 4. But for the non-serous tumors, some people think, well, this shows it's okay to give only 3 cycles. What it really shows is there's no difference, and maybe it's okay to give 0 cycles, but we've never done a study that rigorously has looked at 0 versus 3 or 0 versus 6. We've always assumed that we needed to treat those patients, but that may not be true at all, so something to think about. Now this slide shows you the change in survival over the last 30 years or so for patients enrolled in large phase 3 trials through the Gynecologic Oncology group. And this coincides with the investigation of bevacizumab and the use of bevacizumab. And I was very amused to receive a paper to review from a colleague who said, this proves that bevacizumab improves survival, because that's what explains the improvement over time, is the incorporation of bevacizumab. And of course that's not true, because so many things have changed in 30 years that you really don't know from a retrospective look back which factors were most important. But I've listed all the things that you could say that might have contributed to outcome here, and I wouldn't say that bevacizumab was the major cause, but that I thought it was interesting that someone would look at this and that would be their interpretation. But it is true that I think we probably achieve maximal benefit from surgery and chemotherapy and really need to look at other options for treating our patients. So the last case I'll share with you tonight, this is a woman who had a 15-centimeter complex mass and adenopathy without ascites because it probably wasn't making VEGF. The CA-125 was only 30. And she underwent surgery and was found to have a 10-centimeter grade 3 endometrioid adenocarcinoma of the ovary with surface involvement and invading in adjacent structures. The left ovary had some endometriosis. The omentum was negative. So in the staining you see here, it was wild type for P53, weak for estrogen receptor, stage 2A cancer. And the slide below shows you what it looks like. You can see that it's an endometrioid cancer higher grade. And the CT scan here on the right as well. So what do we do after surgery at this point? This is different than the patient I showed you before, because in this case there was involvement of the uterine serosa, the outside of the uterus, but no actual intrinsic endometrial involvement. So is this a patient that needs chemotherapy with this large ovarian mass, and stage 2 disease, or should they just be observed, or should they get radiation therapy? Radiation therapy, okay. But it's an ovarian tumor, or as I should say, a tumor involving the ovary. Well, the interesting thing was that we went on and did some testing in her case, and a germline panel showed no pathogenic mutations. She did get chemotherapy, was in clinical complete remission, and then her oncologist sent off her tumor for a molecular profile analysis, so next-gen sequencing. That's where it gets interesting. So it first came to my attention when this report came back. And the important thing here are these mutations in BRCA1 and 2. So the question to me was, do you think I should put this patient on a PARP inhibitor maintenance because it's not a serous cancer, it's an endometrioid cancer, but there are mutations in BRCA1 and 2. Should I put the patient on a PARP inhibitor? How many people think this patient should be on a PARP inhibitor? Okay, okay. How many people think they should not put her on a PARP inhibitor? Radiation? No? Yes. Okay. I'm learning, yes. It took me a while, but I'm getting there. Okay, so here's the punchline of the story, is that there were mutations in a large number of genes. The tumor was microsatellite stable, but the tumor mutation burden was very high, 147 mutations per megabase. Never seen in ovarian cancer with, it's rare to see one with over 10 mutations. This was 147. PD-L1 was low. And so the lesion here was a poly mutation because these were all the additional mutations that were observed. So here's an ultra-mutated poly mutation caused endometrioid cancer of the ovary. So her prognosis following surgery is probably pretty good, especially after she did get chemotherapy. She does not need a PARP inhibitor because these are all basically bystander mutations, not driver mutations. And this is a case where you recognize the footprint of a poly mutation rather than the mutation itself, because even the poly mutation at the top of the screen could be a bystander mutation, because everything gets mutated when the DNA synthetic machinery is broken with a loss of poly. So sometimes you don't even see a known diagnostic poly mutation, but you see this pattern that is the result of a poly mutation. So again, is this ovarian cancer or is this an endometrial cancer that happened to take up residence in the ovary? Something to think about. So finally, carcinosarcomas. These are probably some of the more difficult tumors that we treat. Very aggressive. Usually they respond to first-line therapy, rapidly recur, develop resistance, patients die. It's very, very difficult taking care of these folks. There's been a little bit of an advance by recognizing that HER2 is amplified or overexpressed in these cases, and you can add trastuzumab to chemotherapy, which maybe helps, but that needs to be validated in a phase 3 trial that's ongoing, and we'll hopefully get an answer in a couple of years. So very difficult disease to treat. Well, curiously enough, the antibody-drug conjugate trastuzumab deruxtecan was evaluated by Japanese in a phase 2 trial for patients with carcinosarcoma. This is one of the only clinical trials that have ever studied anything in carcinosarcoma. They're usually excluded from clinical trials because they have such a poor prognosis. So here they were deliberately seeking patients with carcinosarcoma. And most of them had some expression of HER2. In many cases, it was 1+ or low-level expression, sometimes higher expression, with or without gene amplification, etc. So the striking thing was there was an overall 54% response rate in the patients that were HER2 high. The HER2 low tumors, there were only 10 that they were tested here, but they had a 70% objective response rate with improved progression-free survival. Nothing has ever achieved a 70% response rate in uterine carcinosarcoma. This is groundbreaking. This is not necessarily practice-changing, but it's certainly thought-changing. And I think, there are now other studies going on with trastuzumab deruxtecan in a variety of diseases with low-level HER2 expression. It's a very interesting thing, important role for the laboratory to be able to measure the HER2 expression and quantitate it, etc. So, I'll skip the platinum resistance and DNA repair stuff for now, just in view of time. But I do want to talk for a minute about measuring HRD. As you know, the current commercial measures of HRD involve what we call sort of changes in the genome that occurred some time ago that are now a fossilized part of the DNA and will stay there forever. It's not a functional assay. It doesn't tell you whether the tumor has HRD today. It says at one time the tumor had HRD, but it may have lost it by the time you're looking now. So something like the RAD51C focus assay, which you see here, can actually tell you whether or not the tumor has HRD today, and would be much more predictive of using things like PARP inhibitors and other drugs. Surprisingly, there is no way to do a commercial RAD51C focus forming assay that I'm aware of. This is really something today relegated to the laboratory, and I'm sure there are some financial logistics behind that, but it's hard to believe that we have an assay that would be 100% predictive of PARP inhibitor resistance, and we don't have routine access to that assay to help treat our patients. So we're treating a lot of patients with PARP inhibitors that are not going to respond or don't need them, and we don't have a good way of knowing that up front. Now, the RAD assay has also been looked at in paraffin-embedded tissue in patients treated with platinum-based therapy, and was also predictive of response to platinum. In this study, this predated looking for PARP treatment in these patients. And so this can even be done on paraffin-embedded tissue that's been around for a while after the patients receive conventional chemotherapy. And then we know there are other genes besides BRCA1 and 2 that can contribute to HRD and can contribute to PARP response, but not all of them. And it seems that these ones on the left-hand side of the slide are more important, and we can see clinical activity with PARP inhibitors in patients with BRIP1, RAD51C and D, PALB2 mutations, not so much in ATM or CHEK2 or some of the others on the right side of the slide. So as far as the trends in adopting neoadjuvant chemotherapy and surgery, we're very familiar with that, and we're waiting for results from the TRUST study. And this has really become the way that many of our patients are cared for nowadays. So there's a lot of opportunity there to get tissue for analysis, but also maybe deciding who does not need surgery, and there are some patients who probably don't. Efforts to study that by looking at various markers have uncovered some pathways around TGF-beta that may predict for suboptimal results from surgery, but they're not quite good enough to use for clinical decision making. But I think that future laboratory studies should help us take care of our patients better and may give us clues about who should be operated on, who should just be treated and monitored. PARP resistance, I will skip. So finally, I just want to touch on the data with PARP inhibitors and outcomes that have been recently in the news. This is the NOVA trial, PARP maintenance, and you can see these very excellent progression-free survival curves with hazard ratios of 0.27 in patients with germline BRCA mutations, and then 0.38 with HRD, and then without mutations, 0.45. So these are very impressive progression-free survival. And we were waiting to see what the survival data would look like from these and other trials. So this is the survival data. Now, survival on this study was a secondary endpoint. There was a lot of patient crossover from placebo to PARP inhibitors of progression. There were patients who dropped out and withdrew consent. There were patients lost to follow-up. So there's a lot of confounding variables that impact the data. And I look at these graphs and I say there's no difference in survival. And this is probably a reasonable real-world experience. So we're using PARP inhibitors. They're important. They're helping our patients in many ways. But the impact on long-term survival in some cases is still a little unclear. Now, FDA looked at these data and other data and said, well, wait a minute. The patients who got the PARP inhibitor are actually doing worse because the PARP inhibitor line is in some cases crossing underneath the placebo line. And that data has not yet been shared publicly, but that's led them to recommend withdrawing indications for the use of these drugs in some situations, which has caused a lot of challenges for our patients around the world. And I hope that we can perhaps undo some of that. So I just wanted to bring people up to date with that. I'm sorry. The final thing is the BRCA reversion mutation. This is another example of an assay that can be very predictive of PARP resistance, but yet not routinely available. When we send out tumors for next-gen sequencing, they will tell us if there's mutations in BRCA1 and 2, But sometimes prior to PARP therapy, these revertant mutations are already there, as shown in the aerial study here, that these are patients, by and large, who had mutations identified prior to treatment with PARP but at very low levels. So they would not be reported by labs today running routine assays of next-gen sequencing. We would need to specifically look for these and report them separately at a higher level of sensitivity, because prior to PARP exposure, they may be less than 1% of the mutations that you might see. But again, we can do that. And we would then know which patients are more likely to have PARP resistance or which patients are more likely to benefit from treatment. So there's two different assays that could be very useful to us in taking care of our patients. Neither one of these are routinely available or commercially available, to my knowledge, really more the focus of laboratory research. So, okay, that we talked about bevacizumab earlier today. I don't need to do that. The ovary has been a very tough tumor to treat with immunotherapy, as you know, and it's very different than other tumors that respond to immunotherapy. And I've just listed some of the things here to differentiate ovarian tumors from other solid tumors. And this study is one that I happen to be involved with, the Imagen 050 or GOG 3015, where patients got bevacizumab and atezolizumab, again, under the assumption that bevacizumab would help the immune response by improving trafficking of lymphocytes and other features. And also had a strong secondary analysis looking at BRCA mutations under the assumption that BRCA mutations, which result in HRD, would improve the immune response because it's like a hypermutated state. It turns out, from what we can tell, that most of these assumptions were totally wrong. So there was no difference in the intent to treat population in progression-free survival or overall survival, and even in the population with the high levels of PD-L1 expression, maybe a slight trend toward improved outcomes, but not statistically or clinically significant at this point. And when they looked at the role of BRCA1 and 2, it was clear that patients without a mutation did worse than patients with mutations, which we already knew. I mean, BRCA mutations are predictive and prognostic for outcome. But when we looked at tumor mutation burden, absolutely no difference between tumors that had a BRCA mutation or did not. So BRCA mutations were not going to be a way to make immunotherapy work better, because they're not really associated with a hypermutated state. HRD is different. And so I'm left with these molecular thoughts for ovarian cancer. We talked about the difference between early stage and advanced stage disease, and could we use circulating DNA, for example, to help better select patients for adjuvant therapy, particularly in the non-serous categories, but also with serous tumors. Many ovarian cancers are extra-ovarian in origin, but the ovary is a favored site for tumor growth and implantation, including what we have previously called synchronous primaries. And the treatment really should be focused on the tumor biology, not where it started. I mean, we have this obsession with wanting to know where was the primary, how do we stage it. Patients want to know, well, where did it start? That's not that important. I mean, the biology and what you've seen here is much more important than where the tumor actually started. It's clear that endometrioid ovarian cancer is really quite identical to endometrioid ovarian cancers, and really has the same mutational profiles as seen in the PORTEC-3 study and the same biology of disease. That should really change how we think about managing these patients. And then I've listed a few other things here, but I mean, there's a lot of questions here that, again, could be addressed in low-cost, pragmatic clinical trials that would give us very important answers that are not going to be funded by the pharmaceutical industry. So things, again, that could be considered in India and other countries around the world. So with that, I will close and ask you, what color is your cancer? I took this picture at the airport in Mumbai on my way over here. And thank you very much. I know it's a long talk. I'm happy to just stop and we can talk over dinner, but if anybody has any questions now, I'm happy to answer any questions. Okay. All right, thank you.